As we are still here with Med School Radio, thank you for tuning back in. If you are one of the 5 people who listened to this video, hope you enjoyed. We're now going to talk about disseminated intravascular coagulation, or DIC. DIC is an abnormal process in which tissue factor or another inciting agent activates the coagulation system, thus causing widespread fibrin formation and subsequent lysis throughout the microcirculation of the body. While DIC begins as a thrombotic process, consumption of platelets, coagulation factors, and fibrinogen generally results in bleeding becoming the dominant clinical manifestation. Another term for DIC is consumption coagulopathy. The major triggering events to unleash DIC are as follows. 1. Release of tissue factor or other thromboplastic substances, e.g. from the placenta or a retained dead fetus. And 2. Widespread injury to the vascular endothelium. Endotoxin, cytokines, immune complexes, and extensive tissue injury can all set off the consumptive processes that underlie DIC. Because of the widespread deposition of fibrin in the microcirculation, fibrin strands shear red cells, causing a microangiopathic hemolytic anemia. This effect has been called clotheslining. In addition, spontaneous bleeding from venipuncture or IV sites and ecchymoses reflect a generalized hemorrhagic diastasis in which platelets and coagulation factors are consumed faster than they are replenished, and in which plasmin drives fibrinolysis. A chronic form of DIC more often occurs in cancer patients, and here thrombotic complications predominate. Migratory thrombophlebitis or trousseau occurs in approximately 10% of patients with pancreatic cancer. Migratory thrombophlebitis is believed to be an example of a chronic, more smoldering form of DIC. Laboratory tests that are abnormal in DIC include platelet count, PT, APTT, fibrinogen levels, and, most telling of all, increased fibrin degradation products. Treatment must be directed at the underlying disease process that set off the cascade of consumptive reactions. So let's talk some more about the thrombotic disorders. Increasingly, it appears that many patients with venous thromboembolism, or which is a deep vein thrombosis or pulmonary embolism, harbor an inherited defect that accounts for the hypercoagulability. And despite the heritable nature, it is unusual for the first episode to present in childhood. With early adulthood the most common time. Pregnancy, surgery, immobilization, and stasis may be important acquired contributors, but many authors believe that all patients less than 70 years of age should be evaluated to determine if they carry a mutation for thrombophilia. Inherited causes of hypercoagulable or prothrombotic states include deficiency of anticoagulant proteins, AT3, and proteins C or S, or increased levels of prothrombotic proteins, including factor V Leiden, the most common of these inherited tendencies, and prothrombin. Indeed, in women who develop thrombosis in association with oral contraceptive use or pregnancy, a significant percentage have the factor V Leiden mutation, which causes resistance to activated protein C, or a prothrombin mutation. The role of elevated homocysteine in thrombosis is clouded in controversy, with only the inherited causes clearly shown to be prothrombotic. Of course, a family history revealing thrombosis is in a first-degree relative is strong evidence for a hereditary hypercoagulable state. Notably, an indwelling venous catheter in an upper extremity is the most common risk factor for venous thrombosis. at that site and usually does not require further studies. Now let's discuss antithrombin 3 deficiency. AT3 or antithrombin 3 deficiency, antithrombin 3 is a potent inhibitor, a SERPIN, of thrombin, the central procoagulant protein in the coagulation pathway. Deficiency is inherited in an autosomal dominant fashion, and there are two types of defects. Type 1 is the result of decreased synthesis of a normal protein, while in type 2 the biologic activity of the protein is drastically reduced. But by immunologic methods, the defective protein can be shown to be present. Venous thromboembolism, a positive family history, and thrombosis during pregnancy are features of AT3 deficiency. The best screening test is the AT3 heparin cofactor assay that measures inhibition of factor 10A. Remember, AT3 inhibits a number of procoagulant proteins. Moving on, let's go on to discuss protein C deficiency and protein S deficiency. First, protein C. Protein C is a vitamin K dependent zymogen that, when activated by limited proteolysis, carries out the inactivation of factors 8A and 5A, two essential cofactors in coagulation. As a result of the deficiency, fibrin generation is unregulated. The most common sites of venous thrombosis are the deep leg veins and the mesenteric veins. A screening test would be a clotting-based assay, but immunoassays are available in coagulation laboratories to determine protein C antigen levels. Next, protein S deficiency. Protein S is a vitamin K-dependent glycoprotein that is a cofactor for activated protein C in its role in inactivation of the factors 5A and 7A. Because protein C and S comprise a biochemical team, a defect in either will lead to thrombosis. As a rule, thrombotic events begin in adolescence and include recurrent deep vein thrombosis, pulmonary embolism, and cerebral and mesenteric thromboses. Arterial thrombosis have been reported in protein S deficiency, while arterial thrombosis are quite rare in AT3 and protein C deficiencies. Activated protein C resistance and factor V laden. Factor V laden was first described in 1993, and the defect makes factor 5A resistant to the proteolytic action of activated protein C, APC, leading to persistence of activated factor 5A, an important procoagulant protein. The point mutation, let me just highlight that. The point mutation responsible involves arginine at position 506 being substituted in a missense mutation by glutamine. This is the site at which APC cleaves factor 5A. Factor V laden is the most common thrombophilia and is believed to account for as many as 20% of cases of venous thromboemboli. Notably, the mutation is thought to have arisen 30,000 years ago in Europe. The mutation is not present in Chinese and Japanese, Native Americans, or African blacks. If a balanced morphism is at work in the persistence of the defect, as in sickle cell anemia and malaria, the trade-off could be decreased intrapartum blood loss or decreased bleeding after trauma. And now we'll talk about prothrombin gene mutation. The substitution of G for A at nucleotide 2210, also called G2210A, increases the synthesis of prothrombin. The mutation occurs in an untranslated region of the gene and somehow increases prothrombin gene synthesis. This mutation is second in frequency only to factor V laden in white populations. Just highlighting this. Comment on the case presentation we have talked about before, but I'll just talk about it again. So, in fact, I think I'll go to the top and we'll just discuss it one more time. Case presentation. A 24-year-old woman is in her 25th week of pregnancy, is concerned because she has felt no fetal movement for 3 days. 3 weeks later, she had not given birth and suddenly developed dyspnea and cyanosis. Her vital signs were as follows: temperature 36.9 degrees centigrade, pulse 102, respirations 21, and blood pressure 80/40. She has ecchymosis all over her body and is oozing from a venipuncture site. A stool sample is positive for occult blood. There are fragmented cells on the peripheral smear. Other laboratory studies reveal an elevated PT and APTT. The platelet count is decreased, the plasma fibrinogen is markedly decreased, and there are abundant fibrin split products. 3 blood cultures are negative. What is the most likely cause of this catastrophic bleeding? We'll go down to the end and we'll talk about what it is. The presence of widespread ecchymosis, thrombocytopenia, increased PT and APTT, decreased fibrinogen, and increased fibrin split products are all consistent with DIC. In this instance, the most likely cause is a retained dead fetus, a grave obstetric complication that can cause DIC because of release of thromboplastins from the fetus. This tissue factor-like material ignites coagulation, causing consumption of clotting proteins and platelets and development of microvascular thromboses in arterioles and capillaries. The platelet count falls falls because of development of widespread thromboses which are platelet rich. Thank you very much.